Participants, we just kindly bear with us, and we are having a last session by Dr. Venkat Kotamraju, who is from Royal Derby Hospital, United Kingdom. Sir is also an emergency medicine training program director, Health Education East Midlands, United Kingdom. He's also vice chair, Quality and Safety Special Interest Group, International Federation of Emergency Medicine. Over to Sir to discuss about ED access block and patient safety.
Thank you very much for the kind introduction. Let me tell you a story. I've worked in emergency departments in the United Kingdom for the greater part of the last 21 years. And I work in two of the largest emergency departments in terms of patient volume. And they are the two largest emergency departments across Europe. If anybody sees more patients than these two hospitals see, I would love to come and work with you. So we see over 800 patients in two of the hospitals in Leicester and in Nottingham. Nottingham is a major trauma center. Okay, so two large emergency departments, but currently I work in an emergency department which sees about 550 adult patients. And we have a separate pediatric emergency department which sees somewhere between 150 and 200. This is over the course of 24 hours. And we are talking about patient safety and ED access block. This is a universal problem. If somebody says, I don't have access block in my emergency department, perhaps you're working in a very cozy private setup, which has got all the facilities to transfer patients out of your department within minutes of their arrival to specialties. So access block and patient safety go hand in hand. And when we talk about access block, in the United Kingdom, we call it exit block. And it is essentially when you have patients who are in the emergency department, they have completed their care, waiting for admission, and they are unable to move out of the emergency department because of various reasons. 15 years ago, the United Kingdom government brought in something called as the 4-hour target. And the target said that in 95% of the cases, any patient who presents to the emergency department has to be seen, treated, and discharged within 4 hours, either discharged home or discharged to another facility within the hospital or discharged out of the hospital to a different hospital, sort of intra-hospital transfer. 1 in 67 patients staying in the emergency department for over 12 hours or greater came to excess harm. The current waiting time in our hospital or across most of the emergency departments in the United Kingdom for somebody waiting a bed is approximately somewhere between 18 and 24 hours. So most likely you will see the same patient who you had discharged waiting for a bed. When you come back the next day, they are still in the emergency department. And the major chunk of the problem for this is crowding. We don't say overcrowding, because crowding kills patients. It is unacceptable, unsafe, and unsustainable care. And this occurs when the demands exceed the capacity of either the hospital where you're treating or the wider systems. And the main contribution to crowding is exit block. We talk about various interventions that we can do in terms of when we say exit or access block, and the key determinant is output. We talk of the determinants in terms of input, throughput, and output. And input is when patients, before they arrive to the emergency department. Throughput is the processes within your department. And output is when they have completed their care and they are unable to move further on in the chain of their patient care management. And this is a big vicious circle, because when you start with output, if you have patients who stay longer in the hospital, and we talked about the KPI in terms of length of stay. And if they have delayed length of stay because of reduced bed availability, that results in crowding. And as a result, you have lots of patients who are unable to come into the emergency department. So the key things of how you measure crowding is delay to ambulance handover times. Our criteria to ambulance handover is 15 minutes from arrival. But last Thursday, I was on call and we had 8 ambulances, and the longest ambulance which was waiting to come into the hospital was over 4 hours. And we can't do anything about it because the walls of the emergency department are not plastic. We are not able to stretch them anymore. And the patients are already in the corridors, outside the cubicles, and there isn't any physical space to put any of them. So delays to ambulance offloading, delays to obviously them being assessed, and that results in long waits. So how does that affect patient safety? Crowding and boarding are bad because it results in worsening of patients' morbidity and mortality. Patients wait longer to be assessed. They wait longer for time-critical treatments. And patients receive treatment that does not conform to guidelines. Also, it reduces patient satisfaction. Patients get frustrated. Their relatives get frustrated. It leads to increased exposure to risk of error, both from the patients, from the patient's perspective, both from the physicians, as well as nursing and other allied colleagues. The risk of readmission increases, and you're subject to lots of complaints, going through a lot of legalities. And this can be particularly challenging in our setup in the United Kingdom, where the average patient who presents to the emergency department, so 80% of the patients who present to our emergency department are patients whom we label as elderly or senior citizens or geriatric patients. And the age groups are usually somewhere between 75 and 105 years of age. So it poses a challenge, crowding poses a challenge to these elderly patients, patients with dementia, patients with acute confusion, patients with learning disabilities, and of course, pediatric patients. So really, as you can see, and you have all experienced access block and patient safety issues, which are directly correlated. So we need to put a stop to this because it's not good for the morale of people working in the department. There are increased risk of errors. There is increased risk of physicians and colleagues being burnt out. So we all need to resolve to really put a stop to access block, thereby to improve patient-centered care. And this is not possible just from colleagues within the emergency department. It's a system-wide issue. We cannot eliminate error. All we can do is take steps to minimize error, take steps to provide the best possible patient-centered care, which is safe, which is effective, which is efficient, which is patient-centered, and which is provided to the patient in a timely manner. And to be able to do all of these things, we need to address exit block or access block, because that is directly related to patient harm and to patient outcomes. So if anything, as emergency physicians, we must resolve to fight for our patients. And that depends on good support, leadership, and support from the top management, and good support from your multidisciplinary colleagues. And unless we have good support from the entire system-wide processes, we won't be able to achieve this. Thank you very much. I'll keep it brief because I think we're just about hitting time, but I'm happy to take any questions or any comments for that matter, because I appreciate There are colleagues who work in different emergency settings across the world, and the practices may differ. But the bottom line is crowding kills, and access block is not good for patient care, and it impacts on patient morbidity, mortality outcomes, and patient safety directly.
Any questions, dear participants? And to the faculties also, anything you would like to ask, sir?
We want to say hi to him and thanks for taking his time.
Thank you very much. Yeah, thank you to Dr. Sarvana and Dr. Srinath. I've only just landed from the UK, so apologies. I had to request them to add me towards the end. So I'm sorry if that has caused any inconvenience, but I thought I should share my perspective because it's a completely different world. And you're more than welcome if somebody is visiting the UK, so please visit our departments and I can show you around to see how things work there. It's challenging to say the very least. And we provide consultant cover for 20 hours out of 24 hours in a day. So we start at 6 a.m. in the morning and we are in the department at least till 2 a.m. So there's nothing like the more senior you become, you can relax at home. The more senior you become, the harder you work, at least in the UK.
Thank you, doctor. Thank you so much for your time. And I'm sure that you are busy there, and we don't want to pull you much of time. So thank you for joining us, and it was wonderful hearing from you and understanding the international perspective. And I'm sure that all the consultants here would definitely admit along with me that in India we are somewhere lucky that we don't have too much of patients overcrowding, and unless it is not a government hospital, but still even our government sectors are having enough bed where we are trying to add, and probably we have challenges with our resources and manpower, but still we don't have issues with beds till as of now, until unless it's not a mass casualty or something. Thanks for doing a wonderful job there, and thanks for joining for this particular beautiful webinar.
Thank you very much. Appreciate it.
So to close the webinar, I would request Ms. Vidyamani to deliver the vote of thanks and also propose about our next coming events at CAHO, which would be really beneficial, and we would be extending and expecting you all to join and be a part of those wonderful learning sessions. Over to Vidya.
Thank you, Abdul. So in the last week of August, on the 30th and 31st, we have our third edition of SACON, the Students' Conference, which is organized by CAHO. It is happening at Mumbai at Narsi Munji Institute of Management Studies. Can we move on to the next slide? We're also having our CAHO Tech conference, which is scheduled to happen on the 18th of October as part of the Hospital Innovations. And the Pitch Fest and the main conference is scheduled to happen on the 25th of October and the 26th of October at Bangalore. Next slide. Yeah. And then we have our annual event, the Patient Safety Conference that is scheduled in the month of April. The pre-conferences start from the 11th of April 2025. And the main conference is on the 12th and the 13th of April 2025. This year it is happening at Delhi. And just before our CAHOCon, we'll be having the CAHO LabCon, which is scheduled on the 8th and the 9th of February 2025. That is also happening at Delhi this year. So with not much of a delay, let me just quickly give away the vote of thanks. So good evening, everyone. And on behalf of the Quality Professionals Wing of the Consortium of Accredited Healthcare Organizations, I extend my heartfelt gratitude to each and every one of you for gracing with your presence for this continuing quality education on patient safety in emergency department. We would like to express our gratitude to our CAHO President, Dr. Vijay Agarwal, and our Secretary General, Dr. Lalu Joseph, for their constant support and encouragement for conducting the CQE series. I would also like to express our gratitude to the CAHO Quality Professionals Wing Chairperson, Dr. Anuradha Pichumani, and our Vice Chair, Dr. Suvin Shetty, for their guidance in the conduct of this CQE. And today's CQE has been yet another successful learning session. I would like to express my heartfelt thanks to the organizing chairman, Dr. Saravana Kumar, and the organizing secretary, Dr. Srinath, for having this well-curated program. Thank you, both of you. Thank you, sir. Furthermore, I would also like to extend our gratitude to our knowledge partners, ASQA and the Society for Emergency Medicine India for their support. We are also grateful to our esteemed speakers and presenters for sharing their expertise and insights with us this evening. And lastly, but last but not the least, I would like to express my appreciation to the MC for the day, Mr. Abdul Dhayan, because he did help in the seamless execution of this particular program. And of course, thanks to all you participants who had joined us this evening. And without you, all this webinar would not have been a success. And also a special mention of our CAHO Secretariat, who've done a lot of coordination for this particular CQE too. Thank you all once again, and thank you for your presence and participation. Thank you.
Thank you.